In this session, we will be discussing how to prepare for the future of AI in radiology. We will begin this session with a discussion of the current state of AI in radiology. We will then build on this background to look into the different kinds of applications that we can see in the near future. We will then move on to an overview of AI application types, discuss how to assess your practice's AI readiness, and we will close the presentation with information on how to integrate AI into clinical practice. AI in radiology is an extremely multifaceted tool, with applications throughout the radiologist workflow, relating both to interpretive and non-interpretive processes. This can affect everything from image processing to diagnostic support to patient safety. When we think about the three main purposes of clinical AI more broadly, a clinical AI application should serve to increase efficiency, improve accuracy, or improve patient care. An application that can address all three would be highly valuable to clinical practice, but an application must address at least one to really be worth investing in. The purposes listed here reflect the capabilities of AI applications that are currently available in the AI market. I'll pause here for a moment for you to read through this list. When we look at where we are now in the field of radiology and clinical AI, it becomes immediately apparent that radiology is the dominant force in the healthcare AI marketplace. Over 2/3 of healthcare AI applications are related to radiology and medical imaging, and there are over 200 FDA-cleared AI applications in radiology. When it comes to the rest of the healthcare field, there are an increasingly large number of applications across clinical specialties, but nothing even approaches the scope of radiology. In fact, cardiology, which is the next most highly represented field, only represents 11% of the AI market share, so less than 1/6 of the number of applications in radiology. This has been in part because of the exponential growth in research and publication of AI research in radiology. Now you may think that with so many AI applications in radiology, and radiology being such a dominant force in the AI marketplace, there must be some exceptionally advanced tools with autonomous and comprehensive AI applications that can perform every task in a radiology exam. And while there are some very impressive and advanced applications of AI in radiology, the field of radiology AI, as it stands today, is mostly made up of applications that are narrow and applications that are brittle. This means that applications typically perform only a single task on a single modality, and very often on a single exam type. One example of this would be an AI application that detects intracranial hemorrhage on a head CT. This application would not detect any other type of intracranial pathology, such as hydrocephalus, stroke, or cerebral edema. And also, this application would not detect intracranial hemorrhage on any exam type other than a head CT, such as a brain MRI or even a CT neck. The development and deployment of more comprehensive and more advanced applications has faced a number of technical stumbling blocks, one of the most significant being problems with generalizability. Generalizability is the ability of an AI application that has been developed and trained on a specific set of data to be able to perform as well on data from the general population. What we have found is that more often than not, an algorithm can be trained to do very advanced tasks with a high level of accuracy on its own limited training data, but when it is challenged with images from other institutions or images from other machines or of a different patient population, performance can be significantly degraded. When an algorithm has worse performance on different patient populations, and it is generating its results in an unfair way or ways that can adversely affect the care of patients in these different populations, that is what is referred to algorithm bias. This is a serious risk for patient care and public health, and a consideration for the ethical deployment of clinical AI. Additionally, the medical legal landscape for clinical AI is still evolving, and challenges in determining liability and oversight for AI is still being determined. Here we have some examples of the AI applications that you can currently find in the radiology marketplace. In the example on the left, we have the tool that most radiologists are most familiar with, which is CAD in breast imaging. CAD stands for Computer-Aided Detection, and this type of AI tool has been in use in radiology since the 1990s and is in wide use today. In the center, we have an image of an application that detects intracranial hemorrhage. This example also integrates with the work list and flags exams with positive findings for more urgent interpretation. In the right of the image, we have 3 more AI applications. Working from top to bottom, we have an ultrasound application that analyzes breast lesions and assigns a BI-RADS score, an application that detects pulmonary emboli, and an application that performs 3D segmentation of intracranial tumors. The current state of clinical AI still has a number of significant questions left to answer. One of these questions is how radiology practices and hospital systems will determine the value of AI in the future. The vast majority of tasks that are performed or facilitated by AI do not have an associated CPT code, so calculating return on investment can be challenging and has to include a more robust analysis of metrics like turnaround times, study volume, subjective measurements like radiologist satisfaction, and so on. There are also questions of what level of AI education is required for the tools that are being brought into clinical practice. Users should certainly be well versed on understanding what an application does and recognizing and troubleshooting errors when they occur. With a single application or a small number of simple applications, this could be reasonably done on a case-by-case basis. But when a larger number of more complex tools are integrated into workflow, it becomes more obvious that a general artificial intelligence literacy will soon need to be part of radiology training and likely medical education as a whole. In radiology, the amount of education and exposure to AI in residency is low, and the options for AI-oriented continuing medical education is even more scarce. The lack of a standard curriculum for AI has been a challenge for radiology residencies and for radiologists in practice who are looking to gain a more fundamental and practical understanding of AI in radiology. Finally, we have the question of patient safety in the use of clinical AI. There is hesitation, and reasonably so, about leaving parts of the clinical decision-making process up to an AI application, especially in cases where the AI decision-making process is not understandable to human users. AI explainability is a feature of AI applications that allows the human users, in this case the radiologist and the ordering provider, to understand what part of the imaging exam led the AI to make its decision. This can effectively allow a radiologist to recognize false positives and false negatives when they occur, and override the AI results when necessary. Another patient safety question is how AI will impact patient care and health equity. This prospect is a double-edged sword, in that advancements in clinical care made by AI could potentially lead to a new stratification of the healthcare system, with more advanced and more high-resource settings using AI assistants to augment and improve their performance, whereas low-resource settings may not have these tools available. But on the other hand, the wide deployment of AI applications may reveal biases in algorithms that may not have been apparent on a smaller cohort. So monitoring is necessary to ensure that the algorithm is performing in an equitable way on different populations in different practice settings. In short, AI should function to lessen health disparities and not deepen them. So now let's look ahead to what I consider the near future of radiology AI. This section will include some discussion of hot topics in AI research that will likely be coming to the AI market in the near future, as well as some novel applications of existing AI tools that could be used in different creative ways to impact patient care. These topics will include the waiting room of the future, the AI second reader, automated report generation, opportunistic screening, and the virtual biopsy. So let's begin this section with a discussion of the waiting room of the future. The current standard for patients presenting for routine exams is that a patient will present to a hospital or imaging center, where the imaging exam will be performed, the images will be acquired and processed, and they will be sent to a work list. Depending on the volume and the turnaround time for a particular practice, a routine exam may be on the work list for hours or even days before it's interpreted. By this time, the patient will have left the imaging center and returned home. But as we all know, it is not uncommon for urgent or even emergent findings to be detected on routine imaging exams. You can imagine a patient presenting for a headache with an incidental intracranial hemorrhage, or a patient presenting for shortness of breath with the pulmonary embolus and right heart strain. The hours that this routine exam sits on the work list are hours of delayed treatment and delayed care. And by the time that the radiologist or ordering provider is notified of the results, the patient will likely already be home, or possibly worse, and could have already experienced an adverse outcome. But with the integration of AI, computer-aided detection tools could help to pre-screen routine exams for incidental, emergent, and clinically actionable findings. As opposed to the workflow shown in the previous slide, in this example, the patient would receive their exam, and while the images are being processed, they are also being sent to an AI server. While the exam is being processed in the AI server, the patient would be sent to the waiting room while their exam is being analyzed by the AI for emergent incidental findings. The processing for the vast majority of commercial AI applications that are available today is in the range of seconds to a couple of minutes. So in a short time after the acquisition of their exam, a patient could receive a text alert in the waiting room saying that their study has been cleared for emergent incidental findings and that the full radiologist report would be completed later. The patient would then be cleared to safely return home. This service could be an impactful addition to patient safety and could help to give patients additional peace of mind when presenting to imaging centers for their exams. Another role that AI applications could play in the near future is that of an AI second reader. When you think about a second reader, you may envision an application that highlights findings on an exam and makes the interpretive process easier for the radiologist. This fits the model of several current commercially available applications, notably the computer-aided detection type of tools, or CAD. But this AI second reader can also play a broader role in the peer review and quality assurance process. Most computer-aided detection tools are deployed prospectively, meaning that they are being used at the same time as the radiologist is interpreting an exam. Algorithms have the capability to analyze extremely large collections of data and could be deployed retrospectively to evaluate hundreds on thousands of exams to assess for how often particular